cataract remains one of the most challenging situation where, we need to deal with a complex surgical steps, and particularly, if you are a general ophthalmologist and, the budding pediatric ophthalmologist. So the purpose of this instruction course is to provide a simplified approach for the management of pediatric cataract to an established general ophthalmologist as well as, the young budding pediatric ophthalmologist. So having said that, why the pediatric eyes need to be handled differently? The basic reason behind is, these kids, the eyeball is, have a low scleral rigidity. So that has a tendency to collapse during surgery and, the post-operative leaks. The second reason is the anterior capsule is more elastic and thereby needs more force, and thus, that has a tendency to run out in the periphery. There is a more severe inflammatory reaction post-operatively, and there is a high rate of, the mitotic lens epithelial cell proliferation that leads to, the high risk of post-operative visual axis opacification. So with this, if you look at the content of this instruction course, we have a very well experienced, the pediatric cataract surgeons with us. So may I request, the speaker, Dr. Shruti Mittal, on the podium, please. She is basically going to talk about, do I need to investigate before I operate and when to operate? Dr. Mittal, please take your seat. Yeah. The second speaker with us is Dr. Sumit Monga. So he is going to teach us, how to calculate the IOL power and what is the prediction error. Can we eliminate this prediction error? The third speaker, myself, I'm going to give you, a glimpse of step-by-step, the pediatric cataract surgery. And the next speaker will be, the Dr. Vaishali Vasavada. Please come on to the podium. She will be tackling, like intraoperative problems in every step and how to deal with them when you are actually come across, the difficult situation when you do all the steps in cataract surgery. And the last speaker, Dr. Sujata Guva, she is going to teach us, this is the most interesting and, the difficult part of, the pediatric cataract, that's called as, the performing pediatric cataract surgery in a difficult situation. So with this, we'll start with our first speaker. So may I request Dr. Shruti Mittal to take her.
Good morning, everyone. So we have no financial interest in this presentation. Let us start with the case of this 1-year-old child who presented to us with a white reflex in the left eye for about 1 month. On a detailed evaluation, he was found to have a total cataract in the left eye, and his birth history and milestones were normal. So what next? What would you do with this child? Would you investigate this child? Would you plan surgery? If surgery, then what would be the intraoperative management for the capsule? Whether will you implant an IOL? If yes, what power? So most of us would agree that every step in pediatric cataract is a controversy. Hopefully at the end of this session, we will be able to clear some of the doubts. I would be discussing about the need for the investigations and the appropriate timing for the surgery in pediatric cataracts. So let us go through some important facts. About 20% of cases of childhood blindness are due to pediatric cataracts. It has a very diverse etiology, with about 51% of the cases being undetermined. So when most of them are undetermined, do you really need to investigate? Well, the answer is yes. It provides a more holistic approach to the patient, helps us understand the risk involved in anesthesia, the risk to the future generations, and accordingly counsel the parents. So every child with pediatric cataract that enters to the OPD should undergo a detailed clinical evaluation. History, including the onset, duration, and the progress of cataract, antenatal history of any fever, birth history, and the developmental milestones, a clinical evaluation of the visual acuity using the age-appropriate methods, cataract morphology if possible on a slit lamp examination, undilated evaluation to look for visual axis obscuration, look for strabismus, nystagmus, both of which are poor prognostic indicators, and a fundus evaluation if possible using indirect ophthalmoscopy or ultrasound B-scan. The morphology of cataract would itself give us an insight into the possible etiology. Like total cataracts are more often hereditary and sometimes in congenital rubella. Lamellar cataracts are usually idiopathic. Uveitic cataracts would present with characteristic posterior synechiae membranes, and subluxated cataracts in Marfan's and homocystinuria. So laboratory investigations, most of us would agree, are not indicated in unilateral cataracts wherein there is no systemic association and no antenatal history of infection. However, any child with unilateral cataract who presents to us with microcephaly, deafness, or other developmental delays should be investigated for TORCH. Traumatic cataracts need not be investigated, and hereditary cataracts need not be investigated. However, more and more stress being given on genetic counseling. If available, a genetic testing can be done in hereditary cases. Bilateral cataracts need a more tailored approach, like depending upon the features that the child presents with. Accordingly, we do a torch, or we do a urine for sugars, RBC galactokinase for galactosemia. In Lau syndrome, we would do urine for amino acids. If we are suspecting Marfan's, we would do a cardiac screening, depending upon the child's presentation. A word on congenital rubella. About 25% of the cases of congenital cataract are due to rubella, and ophthalmologists are often the first point of contact for these patients. About 45% of females in the childbearing age group are susceptible to infection during pregnancy, and therefore an awareness needs to be spread among these women regarding the availability of MMR and the possible prevention of this deadly disease. With more and more stress on genetic testing, according to this paper, the determination of precise genetic cause is possible in 75% of individual families. More than 40 genes have been encoded for 40 genes have been found in pediatric cataracts, and if available, then genetic testing should be done in these cases. This was a 12-year-old child who presented to us with these features. His best corrected visual acuity in both eyes was 20 by 25 and N6. Elsewhere, he was found to have a cataract in the right eye and was advised surgery. His fundus evaluation was normal and his developmental history was normal. So now we know that this child does not need investigations. So would you proceed for surgery? So we need to understand whether this cataract is visually significant or not. It depends upon the history, the visual acuity, the fixation, the presence or absence of strabismus, red reflex on distant direct ophthalmoscopy, and the morphology. So cataracts which are more than 3 mm, central, posterior, and confluent are more likely to be visually significant and should be operated, whereas peripheral cataracts less than 3 mm with clear spaces can be watched. So now the timing of surgery. So most of us would agree that a congenital cataract which presents to us after 3 months of age should be operated at the earliest. But the question when comes when the child presents to us less than 1 month. So this paper by Bursch et al., they found that congenital cataracts, they give us a 6-week congenital unilateral dense cataracts, they give us a 6-week window period during which if the child is operated, the visual outcome is the best. Following 6 weeks, the visual outcome worsens. Similarly, for dense congenital bilateral cataracts, they found that from weeks 0 to 14, the mean visual acuity decreased by 1 line with each 3 weeks delay in surgery, and after 4 weeks was associated with a higher prevalence of strabismus and nystagmus. So, the ideal time for best visual outcome in congenital cataracts would be if the child is operated before 4 weeks. The advantages being that it's the precortical stage of visual development and there is lesser chance of sensory deprivation in myopia. But surgery at such an early age would involve risks with anesthesia, and we all know that early surgery is a risk factor for glaucoma. Open-angle glaucoma is more often seen in these children due to various etiological factors like surgical barotrauma, release of cytokines, corticosteroid exposure, all of which lead to scarring of the trabecular meshwork. So this paper by Vishwanath et al., they found that surgery before 4 weeks in bilateral cases was associated with a higher risk of subsequent glaucoma than when the surgery is performed later. And they suggested delaying surgery until the infant is 4 weeks old. So maintaining a balance between the various complications and the visual outcome, probably 4 to 6 weeks is an ideal time for congenital cataracts. In case of traumatic cataracts, when would you plan a primary lens extraction? When there is an anterior capsule rupture, there is cortical matter in the anterior chamber which would incite an inflammation. Delayed surgery can be planned if there is minimal or focal lens damage or the cornea is severely compromised which would hinder the view. This was a 4-year-old boy who presented to us with a pencil injury to the right eye. On presentation, he had a corneal wound with a total cataract, and the wound was quite peripheral. There was no anterior capsule damage. The advantages of primary lens extraction in this case would be that it would avoid amblyopia at this age. It would provide a clear view of the fundus and help in post-op assessment, and also it avoids the risk of phacoanaphylactic glaucoma at a later stage. However, with the secondary extraction, as the lens is preserved, the barrier is preserved, there's a lesser risk of spread of infection, and when we plant an IOL, we would have a more accurate biometry. So trade-off probably would be to do a primary lens extraction and preserve the posterior capsule and later on plan a secondary IOL. This was a 2-year-old child who presented to us with poor vision in both eyes since birth, and this was his refraction. He had a subluxated lens in both the eyes, and in the right eye he was mainly aphakic undilated, and in the left eye he was mostly phakic in the undilated state. He was given optical correction with contact lenses, and he had a best corrected visual acuity of 20/40 in both eyes. So this case shows that not all cases of ectopia lentis need to be operated. Only when the refractive error cannot be corrected using glasses or contact lenses, or the child has secondary glaucoma or a cataractus lens, do these cases need to be operated. So the consensus is that not all unilateral cataracts need to be investigated. Bilateral cataracts need a very tailored approach. Visually insignificant cataracts should be observed. Congenital cataracts are best operated between 4 to 6 weeks of age. Traumatic cataracts need a more case-based approach. Thank you.
Yeah, so thank you very much, Dr. Mittal, for your wonderful talk. So by the time, I'll call Dr. Sumit Monga. So by the time he'll make, his ready. So basically, what Dr. Mittal has tried to cover, I'll just give you a take home that, yes, whenever you come across with, the unilateral cataract, it's kind of an emergency, so you can operate these patients within 6 weeks. And when it is a bilateral, you can extend it till 12 weeks. But definitely, considering, the fitness for the anesthesia, that all factors you need to consider whenever we do come across with, those syndromic cataracts where you have to look for other anomalies, and accordingly you have to get the anesthesia fitness. Other issue what she has talked about is, whenever you come across a unilateral cataract, you need to find out what is the cause locally, search locally, and then whenever it is a bilateral, then take a proper history, family history, and then rule out whether it is autosomal dominant or autosomal recessive. And when it is autosomal dominant, you know that it's a familial, so you don't need to investigate at all, right? And then once it is a recessive, then you look from head to toe and see that, is it fitting into, the anomaly part, dysmorphic features or non-dysmorphic feature, for which, according to systemic examination, you can guide to your, the pediatric specialist. Yeah. So over to Dr. Sumit.
Right, so very good morning again, and I'm really privileged, to be a part of this IC and share with you, I'm sure all my colleagues would believe, that is one of the most challenging, aspects of pediatric cataract. So I would just start, with a case scenario where, a young child was operated. The cataract surgery were uneventful, and based on the basic principles of counteracting the myopic shift, we would want that the child should be moderately hyperopic at this age. So we made the necessary, rectification. The IOL was decided. But what is this? We actually, when we refracted the child actually had, a myopic shift more than what we had anticipated, at, say, that particular age, whether it was immediately post-op or later in life. So simply speaking, this difference that you have between the predicted post-operative refraction and what you had anticipated is, and what the actual is the prediction error. And we'll come across, this maybe in the initial post-op or in the later, part of the age. You will also come across this term of absolute post-prediction error, in the papers, which basically means that if we ignore the mathematical sign, say suppose, instead of the myopic shift, if this child actually had, like more hyperopia, +6 instead of what you had anticipated, then it would simply mean that the child had an absolute prediction error of 2. So in spite of all the advances, this off-target, that we sometimes get in the, surgery is basically what this talk is all about. What are the possible reasons and how we can actually ward off, based on the evidence in the literature. So simply speaking, when we actually, see that the errors can be at each stage of your IOL power calculation. There could be, measurement errors. Then we'll have, while calculating the IOL power, you can have formula errors. And then you can have conceptual errors, your concept of, targeting a particular error, may be faulty. Or you can actually have, the aisles which have been placed differently than planned, and you couldn't really make the necessary rectifications. That can also lead to, the errors. And then, of course, you have that uncertainty that, the child may have a more exaggerated myopic shift than planned, which can lead to, these errors. So it has been shown that the biometrical errors are in fact one of the most common cause, of the prediction error. And obviously this has evolved, over a period of time. And we know by literature that, the techniques of the immersion biometry and the optical biometry are probably, more superior to the contact A scan, But when it comes to children, you have some specific unique challenges, like limited cooperation or, the inability to do this probably in dense cataracts, apart from, the cost factor involved. So it's a different ball game, for the pediatric cataracts. And let's just, see the hallmark study of IATS, had evaluated both the immersion technique as well as the contact A scan, and they probably didn't really find any gross difference between the two techniques. But one has to understand that their thrust was on good quality A scans, a scan which had good retinal good peaks all along, and we have a good AC depth. So this is something we have to understand, that even if you're actually doing a contact A scan, it has to be a good quality scan that you would eventually, take that. So the take home is that probably, we can do the optical and, the immersion techniques wherever it is possible. Those are superior, no doubt. But then short of it, a good quality contact A scan still is a useful alternative. And probably you can just take, multiple readings and take an average of that before you, decide for your patient. Similarly, it has been shown that for the keratometry, both the automated as well as, the handheld, they compare almost, equally well. And probably, this is also, again, we have to understand that probably your readings that you're taking, actually, they should be good enough. You should have clear Myers, as far as possible. And again, you can probably take average of, the readings. And in case, it's not possible for any reason, because the scarred cornea or anything, then you can probably, take it from the other eye, the fellow eye. Now, I'll just spend a little time on this, IOL power calculation formulas, from the literature. I'll just remind you that we had certain good studies. So this was an extensive age group of 2 to 17 years by Mezer et al., who actually said that, all had unsatisfactory outcomes, but then they had similar outcomes, all the formulae. And then we had this study where, again, there was a younger age group which was taken into consideration. But again, out of all these formulas, they didn't really, find a significant difference in the prediction error. Although this was the first attempt probably, where they split the eyes into different exit lengths and how the, formulas perform. So they found that Hoffer Q is a little better, in those eyes. Then came this study with a very good, a number of patients where, the lesser, younger age group was also taken. And they found that probably the SRK2 is the least variable and Hoffer Q is the most variable, little contrast to the initial evidence. And then, this mathematical prediction model by, Abitz showed that, probably we cannot have, foolproof formula for all the exit length and keratometry ranges, that the pediatric cataracts offer. So this is again, one of the recent, papers where, they had a very good analysis of all the formulas. And the point here I would just like you to note is that the prediction error was, minimal in less than, 50% cases. So it's not that we have to be negative, about it. You have, significant cases where the prediction error is minimal. And even if, the prediction error was a little more, they found that Hofer-Q performed little better in smaller eyes. That was their impression. But this is an Indian experience which was just published in 2012, a study from LVP, where if we just understand, out of all the formulas, probably the SRK2 was the better of the lot. It's not that it was absolutely foolproof, dot on target. We had prediction errors in all the formulas, but in this study where specifically, very young children was taken, they thought that, SRK2 was probably, a little better. And if we understand, this is one of the first studies which actually had a multivariate analysis where, age at surgery, exit length, and keratometry was taken into account. And out of that, SRK2 performed, the best. So basically, out of the existing formulas, we have found that, in pediatric situation, most are reasonable but variable. You can expect, some variations if you use, a particular formula. And the best advice would be that you analyze your own outcomes and probably see what works, best for you. Because, the literature as such, doesn't offer you a very clear-cut choice. Now, when you actually target a post-operative refraction, the thought that comes to you is, are many. What is the age at the time of surgery? How much you would actually aim, whether you will aim low myopia or moderate hyperopia. And then, what exactly is the amblyopic status of that eye? If the child is too amblyopic, you don't want to relieve, too much of hyperopia. And then, what's the fellow eye status, what's the compliance, and what is the parents' refractive errors. So, based on that, we have probably three models. One is, of course, in terms of percentage, the Dahans and, modified Dahans criteria that has been invoked. Everyone has its own modifications. But, this is also one of the useful guideline, propounded by NAD et al., where, just subtracting the age, from 7, you can actually get, the IOL power. And then, you have eminent pediatric surgeons who have their own nomograms, where you can see that compared to 7 years, probably Dr. Wilson's group actually, takes plano at, more than 14 years. So the major fallacy probably, was that we didn't really had a validation of, that, everyone was doing it, but then, how much it really boils down to the post-operative results, we didn't know. So of late, there has been, and this is a very recent 2017, paper where the NAD's, guidelines were validated, and they found that, it works quite decently actually, for them. Although again, we have some prediction errors which are coming, but those were, mainly in less than 2 diopters. And the maximum myopic shift, was probably in less than 2 years age group. But it was less than anticipated. That means you are actually landing up with little more hyperopia than what you anticipate, which again is amblyopigenic. So I think this is a long-term thing we probably need to take care. So the pearl is that probably out of the existing methods of calculating the target refraction, we have systems which work decently well. But then there is a need for further evaluation, on this, and probably we need to validate it more, on a bigger scale. And this is the concept that, we had these pediatric IOL calculators, being propounded, where the difference is that, you have the initial refraction along with keratometry, exit length, and IOL power, and, particular formula feed it, and then you can have a plot of projected refraction at a particular age. Say at 4 years or 5 years, you are actually wanting that at your patient should have this much refraction. So it gives you, that freedom that, instead of, a one-off thing for, at 7 years or 14 years, you target, So if you have a more amblyopic child, probably you can have a more, like better refractive error younger, so that the amblyopia, age can be, you can get over that period, critical period. Then, of course, the lens position matters, where, if you're placing it in the sulcus or, sclera, you need to have modifications. And then one of the things also we have to understand is the A constant. Whatever the formulas have taken, those are on AC depth of adults. Probably if we can actually have a personalized A constants specifically for children who have lesser AC depths, that will be, wonderful. And then, this IIT has also found that for shorter exit lengths, again, the extremes of exit length, basically, the formulas, again, So this is, again, just to sum it up, the approach where, you have consensus between the most, the surgeons who are having most publications. So what they found is that in the target refraction and other, parameters, there was a consensus. That means more than 80% agreed. But for A-scan, probably the A-scan immersion, almost 70% agreed, with that wherever possible. And the important thing is that there was no consensus on the formula, that what exactly works best. So minimizing pediatric prediction error, of course, is not a foolproof science yet. And we need to understand that because the child has some unique challenges of, physiology, and we need to really pay a little more attention to, having an accurate keratometry and biometry. And out of the existing guidelines, probably we can just analyze our own outcomes and see what works best. And obviously, you need a, stringent follow-up to rehabilitate the child in spite of all the, vagaries. Thank you very much.
Thank you, Dr. Monga, for making it very simplified actually, because this is the major issue when any surgeon want to operate the child, where what lens, what power of the lens that I should put. So I guess all of you are now pretty comfortable to understand how to take a decision and decide that this IOL I am going to put. So if anybody has any question, probably you can ask right now, or by the time I'll be ready for my talk. So, or you can jot it down and we'll have a discussion that round.
If I can make a comment, Dr. Vivek,
sure,
on your issue of personalizing the A constant. I mean, in adult cataract surgery, I'm primarily an adult cataract surgeon also. So we have this big deal about you should personalize your A constant based on your surgery. And we recently published this few months back, and we actually did a personalization of A constant even in pediatric eyes, and we took a cohort of only children between 0 to 2 years, because this is the age group when we usually end up with most of the errors. And we found that personalizing didn't make a significant difference. It did improve by a bit, but because we are talking of so much variability, even personalization didn't help us. And contrary to what Dr. Kekune and his group reported, we studied 4 formulae, SRK-T, Holiday 1, Holiday 2, and the Hoffer-Q. And like everyone else, we found that Hoffer-Q gives a lot of variability in pediatric eyes. It had the worst prediction capacity. And the SRK-T and the Holiday 2 were the best in terms of prediction and APE both.
Let's move to the talk which I am going to cover is what are the basic step-by-step approach when you deal with the child. So these are the various steps I am going to deal with. So basically, this is no more something new or difficult for any general ophthalmologist. But here, the point which I want to reiterate is that the smallest length necessary for instrumentation, because the children, they do have a very high tendency of anterior chamber collapse, because when they are in kind of a different stage of anesthesia, their vitreous pressure keeps on changing. So you have to be making these side ports which should be like snugly fit the kind of instruments that you are going to use. The next step, second step is, this is again very, very important step where the size, shape and age of the anterior capsule when you do a rhexis, it is very, very important, because that has a very, very, very immediate and a long-term effect on the centration of the IOL. So even intraoperatively, if you end up with making a large size anterior capsule, then you are in a very tricky situation. So what are the controversies? How to deal about this step? Yes, the people do the manual continuous curvilinear capsular rhexis, then the vitrectorrhexis. Third one is a radiofrequency diathermy and phygoplasma blades. So if you see, the common consensus, at least, the surgeons among, the heavy surgeon who do, the practice pediatric cataract, I think the manual ACC is one of the best. Okay, so what are the precautions that we need to take is that you have to stain the anterior capsule with trypan blue and give a viscoelastic high molecular weight, or depending upon, the comfort of the operating surgeon. So having done that, in this, once you give the nick onto the anterior capsule, then you have to use the, the pediatric capsular axis forceps, and you have to repeatedly grasp the leading edge. And every time, you need to focus it towards the center. So as and when required, you can use a centripetal as well as, the reaping, which we usually do in adult cataract while doing the adult cataract anterior rhexis. So if you are a novice surgeon, always it's better to aim for, the smaller size rhexis. If you end up with a larger size, then, it's very difficult to tackle. So how to tackle, our next speaker, Dr. Vasavada, will take care of that. So as a novice surgeon, always aim for the smaller size capsule opening. And as and when required, you can always, do a double rhexis and enlarge it to 6 millimeter. This is the third step. Again, there are varieties of approach. If you are a SICS surgeon, if you are a very expert phaco surgeon, there are varieties of ways, like, one can use a phaco handpiece, automated irrigation aspiration, single port cannula, as you can appreciate in this video. You can use, Simcoe cannulas, as well as, the vitrectomy probes as well. So some vitrectomy probes, they do have a both function, cutting as well as suction. So you can use simultaneously for both the steps. Going to the fourth step, lens aspiration. Again, there is a common consensus. This is not at all a difficult step. All the, the adult as well as the pediatric cataract surgeon, they could perform this step very easily. The only important thing is, as a novice surgeon, if you are not comfortable, dealing with a very smooth lens material, you can always hydrodissect, so that, it gets completely separated from the underlying capsule, and it's easy to, remove the lens matter. So basically, the bimanual automated irrigation aspiration is the best at this time point. You can see that, you can do first hydrodissection and then do, basically it reduces your surgical time. Then this is again very, very vital step of a pediatric cataract surgery, because if you do not perform this step properly, we end up with, getting early visual axis opacification. So there are two ways. You can do either the manual approach, like you can use the pediatric capsular axis forceps and perform the way very similar to that of the, the ACC. But here you need to take care about, the holding the posterior capsule, because it is too elastic and very thin. And the very important, step that you need to take care is that you don't put the viscoelastic, too much, so that it will be too deep. Because once, the antechamber becomes too deep, then it goes beyond the, the fine focus of your microscope, and then visibility get disturbed. So keep as much comfortable shallow as you can, hold it properly, and then, they initiate in a similar fashion as that of the ACC. There is one more way. You put the IOL first, and then, take your vitrector underneath, negotiate the IOL, go behind, and then you can do a vitrectorexis. Believe me, for the novice surgeon, I would suggest this is a very good, very simple technique and very safe one. And you are pretty sure that, all the time your lens is in the bag. Because if you go by the first approach, if you are not an experienced surgeon, then probably, there is a lot of difficulty when, the leading haptic goes into the vitreous cavity, or, you have to manipulate and bring it into, the two, kind of large openings, and then you have to put in between. So until and unless you have a very good experience in that, it's very difficult to perform that step. So I would suggest for the novice cataract surgeon, I think putting the IOL first, followed by, doing the PPC with the vitrectomy is the very easy technique. Then what are the controversies as far as the PPC is concerned? What is the approach? What should be the approach? Is it an anterior or is it a pars plana? So for my own practice, I would say probably all the speakers they would comment. I usually prefer the anterior approach, and implant again, as I said before or after, depending upon the expertise you are doing that particular step. And size is, yes, it's a 4 millimeter, that is a common consensus. As far as the anterior vitrectomy is concerned, again, whether it should be anterior or pars plana, and at what age, before or after 7 years. So, the literature evidence, it says that, less than 7 year, we should all the time attempt for, the anterior vitrectomy, and beyond that, you can skip this step. So, I'm sorry, yeah. So, what are the current consensus about this step? So, the primary PPC with anterior vitrectomy for children less than 6 year to 7 year of age. Then PPC without anterior vitrectomy for more than 7 year of age. And you can left, the PC intact in children above 9 to 10 years of age. As far as size of the PPC is concerned, it should be 1 millimeter less than the size of the optic of the IOL. And approach in my practice, preferably for limbal, but pars plana approach is also recommended. And specifically, whenever you are dealing with that approach is very useful when you are dealing with the visual axis opacification, very fibrotic. So you can go pars plana and remove very nicely the visual axis opacification, and you can enlarge the size of the PPC. Time, again, before and after IOL implantation, depending upon the expertise. Then surgical incision, this is again very, very important step. Scleral incision, it's very difficult to perform due to the low scleral rigidity. If you are a phacosurgeon, then definitely, the clear corneal or a limbal approach is the best one. But if a SICS surgeon would want to, put, depending upon, the logistic available, if you want to put a PMMA, probably, the scleral incision would be better. And what are the advantage of, obviously, of the clear corneal or the limbal incision? It is safe underneath the upper eyelid, near the limbus, so there will be the maximum healing, easy to perform, and less likely to traumatize because of, the protection by the orbital rim. Then implanting the IOL. This is again very, very simple stage for all general ophthalmologist and phacosurgeon. There is nothing great in this step, but you can use varieties of IOLs, but standard of care as of now is the Acrisop single piece in the bag all the time, and depending upon the indication you can put the multi-piece IOL in the sulcus, and definitely adjusting for the the position of the IOL under correction. So size of the IOL less than 2 year, overall diameter is 10 millimeter, and more than 2 years for the adult standard size what we are using it, because by that time like 90% of the eyeball is as that of the adult eyeball. Preferred IOL hydrophobic, acrylic, single piece or 3 piece, and these are the absolute contraindication. Uveitis is nowadays no more the absolute contraindication. We can always control the inflammation in a proper way and then take the patient for putting the IOL. This is the last step, wound closure and subconjunctival injection. It is of utmost importance, particularly in children, because they have a decreased scleral rigidity and thin sclera that needs a special attention, because there is always a chance of mouth fishing, like fish mouthing of the internal leaf of wound, and because the child age, particularly those child who are challenged, there is a very high risk they'll hit and your wound get fish mouth. So there's a very high chance of leakage, post-operative hypertony and infection. Subconjunctival injection, in my practice, we had we used to give a subconjunctival gentamicin, but that has the tendency to go inside, particularly when you are planning aphakia, retinal toxicity. So in my own practice, I prefer giving subconjunctival dexamethasone to tie over, the acute post-operative inflammation. Thank you very much. I'll call Dr. Vasavada. So basically, just now we have learned what are the basic steps of, the pediatric cataract surgery. So she is going to tell about how to deal when you are operating and go wrong. If you are doing a ACC and it has got extended. So how to deal each and every step when it goes wrong. Dr. Vaishali.
Thank you, Dr. Vivek, and good morning, everyone. It is really heartening to see ourselves positioned in a smaller hall and yet with a jam-packed hall, first day early morning session. So congratulations for this great course that you have put up. And I must say that I am presenting today on behalf of my colleague and friend, Dr. Preeti Patil Chablani, who couldn't make it here. And like Dr. Vivek said, I want to talk about intraoperative difficulties. I don't necessarily mean complications, because to my mind, every step in the pediatric cataract surgery is a potential difficulty unless you deal with it in the very meticulous way every time. It's not like you can, just because you have been operating for X number of years, you will be able to get it right every time. And we have no financial interests. And like has been discussed, the whole point is about small details, which are often missing and so very different from an adult cataract surgery. So the point is concentrating on every small point. And like Dr. Vivek highlighted, in incision, unless you are planning an IOL implantation or you have to enlarge the incision for whatever reason, you want to make as many number of small incisions that you can, side port, they could be 1 millimeter, 1.2. But what is important is to understand here, this is a video that I borrowed from a study that we performed in an adult eye. Just look here, this is a side port, this is a 1.2 millimeter side port, and following lens removal we had put trypan blue on the surface of the eye, and with the speculum in the eye the patient is asked to blink and see what's happening. The trypan blue is spontaneously going inside the eye. So if this can happen in an adult eye, God forbid what can happen in the pediatric eye. So we have to pay attention to even construction of the smallest of small incisions, for which, like he said, use an MVR knife. Don't use the stab knife, side port. That should never be used for a pediatric cataract. And as many small incisions as you can. I often make 3 incisions to start off with, because I like to be bimanual in my pediatric cataract surgery. I want to, even during my rexis, I'll use the forceps with both hands. And then obviously every incision in a pediatric eye has to be sutured to avoid any difficulty. You may not get an endophthalmitis, but a lot of the times we see that post-operatively these incisions have synechiae, and these can lead to not only bad cosmetic results, but photophobia, exposure of the optic edge, and many such problems that we understand. So even the side port incisions should be sutured, even if they are older children, 7 years, 8 years old, because they are all eye rubbers. Now here is a case we see that it's an extremely small pupil and it's a 360-degree synechia. This child has a juvenile rheumatoid arthritis. What I want to highlight here, I haven't made anything. This is the first incision. Now I'm going to have to open this pupil up, and my choice is the iris hooks or the iris retractors. Now this is a 1.2 mm dual bevel knife, but just see when I make the incision. I didn't penetrate full width. This is the maximum width until which I'm not reaching. So again, like I said, a small detail, but very important, because you're going to make 4 of these, and you have 2 for your bimanual IA, and then you're going to put in an IOL. So please make as much small as you need for that particular step. Now through this small, less than 1 millimeter incision, I could easily implant my iris retractor. And at this point, there is no viscoelastic in the eye as well. So I'm using these iris retractors as a dual purpose. I don't want to go in this eye and try to put my spatulas or V-hooks and try to break off the synechia, because I'm scared that this fragile capsule might tear at places or I might damage it. So I'm using the same iris hook without any viscoelastic in the eye, this is unedited, to retract the iris as well as break as many synechia as I can. And in between, if I want, I do use some BSS. And you can see that I am positioning the 4 hooks here, and they are automatically opening up most of the synechia, and the rest of it I could easily swipe a spatula, and because since now I have a plane. So that is one small tip that I find very useful. Now there are these 2 adhesions which can easily be swiped off with your spatula, and then you perform a trypan blue staining, so that now you can also see your capsule very well. Now if I had put in a viscoelastic before I do my trypan staining, we all know that although you can do it, but it becomes very messy, and sometimes you don't get a very uniform stain after, especially if you're using methyl or Hilon 5, Hilon GV, these very heavy or dispersive viscoelastics. So this I thought is a useful thing that I should share with you. Now going on to the rexes. We know that it is a sheet anchor for pediatric cataract surgery, and Dr. Vivek rightly pointed out in his talk on the posterior capsular rexes that viscoelastic in pediatric surgery is a boon and a bane both. Typically we all use very heavy viscoelastic. My personal choice is to use Helon GV, which is 1.4% sodium hyaluronate, or Helon 5. Helon 5 is the best viscoelastic for pediatric rexes, irrespective of any financial disclosures or interests. And although it means spending that extra 2,500 rupees, I would rather spend it, make the patient aware and get them that injection so that I can do a rexis. Now with a heavy viscoelastic, unlike methyl or simple 1% sodium hyaluronate, you have to be very careful when you inject. If you have too much, it pushes the rexis tear away. Not only does it not help you. So what I'm doing here is once I've done my staining, I'm just doing small pockets of injection, as you can see. I'm not trying to stay in the center and just inflate the eyeball in one go. So that is something again which will prevent a lot of difficulty. And now I'm going in the center, having first flattened the mid-periphery, because this is the working area that I want for the rexis. I really don't want it too much in the center. So this is something which will prevent a lot of difficulty. The other point, like Dr. Vivek was saying, this is me, and I said, I use 3 incisions and I use both hands when I'm performing rexis. And you can see that I'm not being able to control the rexis size very well. So how do I do it better? Using these micro incision forceps, I'm trying to hold the flap multiple times and with multiple side ports. So you see here that I'm becoming a little bit more confident or more aggressive. I should be holding my flap here, closer to the flap rather than so much away. And so I'm not being able to get a great control on the rexis. But then I realize it, and so I start pulling it upwards and centrally so that I can control the size and now join it to my desired size. So again the point here, bimanual work, instrumentation is something we all should learn, and we are all very good at in pediatric cataract surgery, because that is the only thing that will help us. Now here is that previous patient where I showed how you would inject viscoelastic. You can see a huge anterior capsule plaque which is slightly eccentric. So how do I begin a rexis? I have started in the center, which is the anatomical center of the eye. But this is a place where it will be very difficult to penetrate the capsule. And in doing so, I'll have to stress a lot of the zonules because I'm just pushing and pushing. So I decide to puncture this with a straight 27 gauge cystotome needle at the edge of the plaque. And I'm aspirating the lens material because it is a white intumescent cataract. I've stained the capsule, of course. And now, using this opening that I've created, we are using scissors to create a flap. Once you are outside the plaque area, you could even switch back to your forceps, and at least till this point, when you reach here, use your forceps. So you can always keep changing your strategy. There's no one fixed point that you have to use a scissors or a forceps or only one incision. The main section that I wanted to concentrate on today was the approach to vitrectomy. Now, I trained with my father, Dr. Hasavda, and he's a big proponent, he still is a big proponent of anterior approach, manual posterior capsular rexis, and he does it like magic. But I'm not as skilled as him, and I was a beginner surgeon. So what do? I am not confident that in the younger eyes, less than 6 months, less than 1 year, I'll be able to achieve a PCCC all the time of a desired size and centration, like you said. So I prefer, in a lot of cases, especially below 1 year of age, to go directly with the pars plana vitrectomy approach. Now this becomes even more relevant when you have a posterior capsule plaque, or if it is eccentric, or if it is a large plaque. You know that you're not going to be able to create a rexis of your desired size. So why do I do it? Because it is more effective even for the vitrectomy. If you were to do a limbal vitrectomy, what you're actually doing is you're pulling the vitreous to the front with your vitrectomy probe, however good your cut rate may be. Whereas if you're going pars plana, anyone who's a retinal surgeon will tell me that you are doing the right thing by approaching the vitreous where it is. So you're not dragging more vitreous, and you're effectively achieving a more symmetric removal of the anterior vitreous, which is the whole idea in this surgery. What extra instrumentation do I need? If I can do it, anyone can do it. This is what I believe. All you need is either a trocar cannula system, which is available with a lot of good phaco machines. So if you are in a setup which has a decent phaco machine, you will probably get access to these. If not, you can always use an MVR knife, and all you need is a caliper. Other than that, you don't need any instrumentation, you don't need any learning curve or extra surgical skill. Any gauge of vitrector, 20, 23, 25, 27, whatever you like or whatever you have will do, depending on your system. So here is a child, this is a 6-month-old child, and if you can see there is some plaque element also. So I'm going to pre-plan a trocar. The key thing is that these eyes are very soft, they are so squishy that once you open them and then you think that now I'm going to put a trocar, it's going to be extremely difficult. So whenever you are anticipating a pass planner approach, please put in a trocar, if you have a trocar, or do that lance knife entry. The caliper is marked at 1.5 to 2 millimeter. In really young eyes, I would put it at 1.5. And now I'm doing a marking before I proceed. So I have marked the area where I want to enter with my trocar. This is before doing anything else. The next step, now this is a 23 gauge trocar. If you will notice, I want you to see here that this is the intended point, but I just don't go in like this. I first grab the conjunctiva with the tip of my trocar, being beveled, and then I turn downwards towards the optic nerve, and you can see how much it's not very cosmetically appealing when you look at this, but that's even when the eyeball is intact. Now imagine that once you have opened this eyeball and you have to push in this trocar, it's going to need a lot of force. So all you have to do is make again, go towards the optic nerve. Don't keep it beveled. Keep it straight towards the optic nerve and insert the trocar. This may be valved as in this case, or you might have to just plug the trocar and then move on as if you are doing it normally. The other point for pars plana vitrectomy is that do it where you think is going to be ergonomically comfortable for you at that stage. You may be left-handed, right-handed, it doesn't matter. Now in this eye, this is the superior aspect, and I feel that I have a much better exposure, and when I'm working in this area, I will insert my vitrector to this orange port and my irrigation through the left side. So that is what. If you don't have a trocar, nothing to worry about. You can put in your IOL, suture the incisions, and make with an MVR knife 1.5 to 2 millimeter away from the limbus. But again here notice the direction of the knife. It is going like this. It's not going parallel to the iris. And then after doing the vitrectomy, these must be sutured. If you are making an opening in the sclera, which is not a trocar, please suture it whatever the size, because these eyes, as we saw, are very leaky and very compliant. Suture the conjunctiva also separately, because suture exposure is a definite possibility in these eyes. Now here is a video where you will see, I apologize, this is below the drape, but a pars plana trocar has already been inserted. The surgery went off okay, ACCC, and now IOL is being implanted. Now having done that, I have introduced my vitrector through this trocar. This is a little older video. On this machine we had a cut rate of 2500. Now we have a cut rate of 4000. So you really can't make out whether it was a manual or a pars plana rexis. And using that and a modest vacuum and modest bottle height. Your bottle height should not be very high because you don't want the whole thing to drop too much posterior. So you control your size, you control your rexis, and notice that the irrigation is still in the front. So we don't have to make 3 ports, or we don't have to be retinal surgeons to do this. I put my irrigation through the side port, corneal side port, and just the vitrector goes behind and performs the vitrectomy and comes out. So I think this is a very, very convenient, very easy approach. It's just a little bit of a mental hurdle that we have to overcome. Now here is one case I want to show. This is the one that I showed you in the beginning, which had an anterior capsule plaque. Now because I noticed that part of it has been done with scissors, here, this is all scissors rexis. And we all know that whatever you do, a manual rexis is gold standard in terms of its tensile strength. So I want you to notice what happens because I made a lapse of judgment. Now good sense would dictate that once I am done with my IA, before I retract my irrigation, I should have injected viscoelastic through this side port to form the chamber and then remove. But then sometimes we get, like I said, I got confident that I'm the greatest surgeon on earth and I can manage whatever comes in my way. So keep a note on this area. Did you see this? So that apparently intact rexis just gave way at the end of the procedure. I must have swapped 100 times when I was doing IA, but nothing happened. It was an intact rexis, but it was a scissors cut. So it is always a weak point and it gave way. Now this child, I cannot see where the tear has gone. I tried to do it with V-hooks, but I couldn't see where it is behind the iris. So now what do I do? Should I implant in the sulcus or in the bag, or what should I do? Now I do also want to do a vitrectomy because this is a child below the age of 1 year. So what do? I enlarge my incision, and this time I enlarge it generously. I don't want to make any show-offs that I do only 2.2 or 3 millimeter. I don't even measure it. I enlarge it to a size where I feel comfortable to implant the IOL. And now I'm using a 3-piece foldable IOL. Now in this situation, there is no argument against single piece. I could even do that, but I preferred a 3-piece because in case there is an extension and I have to do a reverse capture or bring it back to the sulcus, single piece is not done. Therefore, I use a 3-piece foldable lens. And a lot of us who trained with single piece IOLs to begin with, in our generation, we haven't used 3 pieces that much. So I wanted to highlight some points. You notice that I'm not using an injector system. I'm using a holder folder, which is a manual way. It needs a little bit larger incision, but at least you can go and put that IOL inside the eye, which is what I wanted, because I don't want to stress the margins anymore. Otherwise, that tear is going to go through to the posterior capsule definitely. So I'm giving counter pressure with my spatula, with my Lester hook actually. And I'm going inside the eye with the whole optic. Now this is an unedited video, so it does look time consuming, but I do want to make sure that the leading haptic goes in the bag. If it goes in or if it gets stuck in the rexes, it is going to stretch this already torn rexes. And I make the effort to go all the way inside the eye, and then I release the optic, so that it becomes easier for me to do it without stress on the capsular bag. Now all I have to do is use my Lester hook, and there's no dialing. You have to push down. You have to engage it at the optic-haptic junction and then push down, push and dial. You can't just dial. If you keep dialing, nothing will happen. You have to push down, so it doesn't look very elegant, but you have to give a little vertical force, and there it goes inside the bag and everything is fine. And now, fortunately, again, the good part here is that I was already planning a pars plana vitrectomy, so all I had to do is just go behind, do a vitrectoraxis, and I could manage the case as I wanted. Final word on what is an adequate vitrectomy. Triamcinolone staining is the answer. Now look at this. This a PCCC was done, and who would suspect that a vitreous strand would come to the incision unless you actually used a triamcinolone. And therefore, you can confirm adequacy of your vitrectomy. And this should be done even in any case after the IOL implantation. In case there is any vitreous in the anterior chamber, please go ahead and do a bimanual vitrectomy. Thank you.
Thank you, Vaishali, for the wonderful talk. So I'll invite, Dr. Sujata Gua. She is going to talk about, the pediatric cataract surgery in difficult situations. So by the time she'll get ready, I'll just give a few, the comment was Vaishali has tried to, teach us is that, particularly, when you are putting this 3-piece IOL, with the company they give, the B type of cartridge. So it's very difficult to put it actually, until and unless you snugly negotiate that, the one knob is there on the, the trailing side, and then you have to put that trailing haptic first, and then you have to push the IOL within the cartridge. If you fail that, then 100%, your trailing haptic is going to break. So this is very important point. Yeah. So this is one way of like holding and then putting the.
True. And like I said, people. Those who have used, I see a lot of my senior teachers and colleagues who have used a lot of 3 pieces. For them it may not be as difficult.
It's for a noise.
But for people like us who already learned SICS with foldable IOLs, who did pediatric cataract surgery with foldable IOLs, single piece, 3 piece, you do need a learning curve, and in pediatric you don't want to mess around.
Dr. Sujata, please.
Good morning, everybody. So now that you've heard about all the normal situations in a pediatric cataract surgery, I'm going to discuss a few of difficult situations and how differently we'll approach them. And few of those situations are small pupils with uveitis, a fibrosed anterior capsule, fibrosed posterior capsule, ruptured posterior capsule with anterior cortex in the anterior vitreous, small pupils, fibrosed anterior capsules, and subluxated lens. So let me do them one by one. Like Dr. Vaishali has said, if there is a small pupil, my choice is also, my choice of surgery is also iris hook. And in this, I will again give you a tip. When we put this in, you can use a 26 gauge needle opening. So you can just bend the 26 gauge, make the opening with the 26 gauge needle, and these iris hooks go in through the 26 gauge very beautifully. And you don't even collapse the chamber, and you don't need to hydrate these wounds. So you can do the iris hooks. You can have these push-pull hooks, which is the Kuglen's hooks, to break the sphincters. And suppose you don't get adequate opening, you can also use what we call as the cutter to do a pupilloplasty. I know that you kind of damage the iris, but however, in some situations with persistent anterior hyaloid with fibrosed vascular capsules, you can use the cutter to do a pupilloplasty. It will help seeing the fundus at a later date. And sometimes when we don't intend to put the lens, we don't even need to increase the opening, especially if we are little experienced. You can just retract the iris and increase the size of the rexus under the iris. Here I'm using a 27 gauge butterfly needle as the irrigation because I want a snugly fit chamber. Now the second situation, when we have a very fibrosed anterior capsule, well, rexus forceps will not help. You have to use these scissors. These are intraocular scissors, and you use a robust intraocular scissor to make an opening. Once you have made an opening, you can go with a cutter. Without the opening, if you go with a cutter, you won't be able to put your cutter through and cut the fibrosed capsule. So you have to make an opening with a scissor and then use the cutter and increase the opening size to the desired size. Now, this is from Dr. Vasavada's group. They described 3 types of anterior hyaloid, anterior persistent fetal vasculature, and the fibrovascular tissue type is the one which I showed you. And interestingly, 90% could be approached through the anterior approach. A word of caution, if you have ciliary processes coming into the anterior capsule and you can see them through the pupil, it is better to approach from the posterior route because you can anticipate serious bleeding in these cases. Now the next situation will be a posterior lenticonus, which most of the time, if you have a total cataract, you will completely miss. So you really don't know what you have inside a total cataract. So unless otherwise specified, you will treat this as a posterior capsular dehiscence with posterior lenticonus. And you need to do you don't do hydrodissections in such cases. Similarly, post-trauma, in this case, with a total cataract, what you can, you see a total cataract and you don't know what is behind. So don't do any hydrodissection in these cases. You might drop the cortex into the vitreous cavity. And you can see that we are approaching the cortex from the periphery. And once the cortex is gone, there you can see cortex in the anterior vitreous cavity, and since I'm doing it with a cutter, you can actually take it out without having to call your posterior segment surgeon. Now, Dr. Vaishali had mentioned about a posterior capsular plaque. You can tackle it in 2 ways. Either you can peel it or you can use the rexus forceps. Now, when you attempt to peel it, if you find a cleavage plane between the plaque and the posterior capsule, it is very easy to peel it off. If there is an adhesion, then you will stretch your zonules and damage them very badly. And that is the time when you need to use your cutter. Here you can see we have finished the anterior rexus, and I will use the spatula to see whether there is any adhesion. I can get a plane or not. There, I'm doing it. I don't get a plane. So I immediately convert and use the vitrector to do the posterior capsulotomy. Again, this is a fibrous plaque, which it's fibrous plaque in the posterior capsule. Like again, Dr. Vaishali said, you make an opening with a sharp instrument. I'm using a 26 gauge needle. You can use the MVR blade or any sharp instrument to make an opening, and then you can use the cutter. This is not a CCC, but however, since these are the fibrous capsule, they are pretty strong, and you can put in your lens without stretching the capsule or extension of the capsule. This was a 14-year-old child who was one-eyed, and the other eye had granulomatous uveitis with a visual acuity of counting finger. Again, we made sure that the AC was quiet for the last 3 months. The vitreous cavity was quiet. There was no echoes, and the UVM showed no echoes in the pars plana. And we took this child up for surgery with a very intensive pre- and post-op steroids. And post-operatively, this child did very well. The surgery for this child, if you can see, the synechia are not too dense, so we did use the spatula to swipe the synechia away. Unlike sometimes in post-traumatic cataract, the synechias, when be very thick and very adherent, there you please don't use the spatula like Dr. Vaishali said. You use sharp dissection to separate the posterior synechia from the iris from the capsule. And then if we don't do normally posterior capsular excess in older children, however, since this was a uveitic eye, we anticipated postoperative inflammation. We did a posterior primary capsulotomy. And in uveitic cataract, you have to put the lens in the bag. Do not put any lens in the sulcus in a uveitic child. If you can't put it in the bag, do not put the lens. A good phakic eye in a uveitic child is better than a bad pseudophakia. So the choice of lens will be acrylic lens. In the era before acrylic, it was PMMA with surface modification, heparin surface modification, but now with acrylic lens, it will be the acrylic lens as a choice of surgery, and it will need to be in the bag. Remember, only and only in the bag. Most consensus is towards IOL these days, so IOL is not a contraindication in uveitic eye even with JRAs. So in uveitic eyes, make sure the eyes are quiet and use intensive steroids, and the choice of lens is acrylic in the bag. Now this case, this was a child with a firecracker injury. It was a total cataract, and post-op and pre-operatively, the ultrasound showed normal fundus. But in UBM, there was a dehiscence in the posterior capsule with cortex in the anterior vitreous cavity. So here, when we did the surgery, we called in our retina colleagues because we did not know what to anticipate. But however, we could approach it from the anterior route and take off before those cortex dipped into the anterior vitreous. Another thing about traumatic cataract is that the zonules may be a little weak. So if you have a situation where you have this primary wound repair done and there is a little weakness, you will see during rhexis, the rhexis tends to increase where there is a area of zonular weakness. So you need to use a good viscous viscoelastic and do the rhexis carefully with these micro-rhexis forceps. And you can use the haptic of the IOL to support the zonular weakness. So in traumatic cataracts, when do you intervene? You intervene when there is a ruptured anterior capsule and causing raised IOP, causing uveitis, or there is a decreased visual acuity. If there is a traumatic cataract with a small rosette with good vision, do not operate. Now again, this situation where this is ectopia lentis with the right eye having the lens like this with most of the visual axis aphakic, the left eye is most of the visual axis is phakic. And the visual acuity we started with 636 was being improved with part-time patching in the right eye, and in the left eye, in the phakic eye, it was 6 by 7.5. So both eyes had good vision. So the question is, do we operate these cases? When the vision is equal in both eyes, we avoid operating subluxated lens because surgery in pediatric cataract can be followed with retinal detachment. In Marfan's, retinal detachments can be very, very difficult to treat. You can do a lensectomy with scleral fixated lens, which is again in very small children. Since the pars plana is not well developed, you tend to avoid and get them through to a little adulthood with contact lenses. And or you can use the Sionese ring, which is again very difficult. So you watch them till they have good vision. To summarize, if you have a small pupils, you can use this iris hooks through a 26 gauge needle opening. If there is a fibrous capsule, a rhexis is with a forceps is not possible. Please use the cutter or the vitrector for the rhexis. If you have a traumatic cataract with a pre-existing dehiscence, avoid, you have your vitreoretinal colleague in place, but most of the time you can do it from the anterior approach. In uveitis, remember IOL, acrylic in the bag, otherwise in the sulcus, no IOL. And make sure the eyes are quiet perioperatively. In trauma, the timing of the surgery is important, and if it's a total cataract, please do a UBM to find out whether the posterior capsule is intact. And with a subluxated lens and a good vision, please follow up these cases. Don't be in a hurry to operate. Thank you.
Wow, very wonderful videos. It was amazing, the video session. Thank you very much, Dr. Guba. So basically, I'll just summarize what she has actually, tried to teach us about, how to deal with the cataract in difficult situation. So as she has said, in PHPV, when you are actually planning to operate this patient, it's very important to, be ready with, the endocautery, because you don't know at what time point of the surgery, you come across with, the profound bleeding. So I think that is a very important point, and as you rightly mentioned, whenever there are the plaques, then you have to find out the way how to negotiate them. I mean, either you can use the MVR or the needle to prick it, make an opening, and then start to use the cutter and complete your the PPC, or as you have shown that you can that is the ideal way, go from the pars plana and get the best the vitrectomy, even vitrectomy 360 degree. So, which is the best situation. So, if you are a kind of a limbal approach surgeon, in my practice, I reduce the bottle height so that I don't want to be very deep anterior chamber, and then I make sure that the margin of the PPC is having all the time kind of a flutter movement to make sure that I have done the 360 degree nice vitrectomy. So, if there are any questions, we have ample amount of time to take the questions. Yeah, please. Yeah. You can please come near the mic there. Yeah, center.
I'm Dr. Kalpit Shah from Ahmedabad. Regarding the anterior capsular plaque, like in case of anterior PHPV or other simple anterior capsular plaque, sometimes it happens the plaque is more than the 6 millimeter. So in that case, we use the micro scissor to complete the rhexis. So we put the multiple cuts and we complete the rhexis. But last 4-5 cases, I started and I felt like it is working, like reverse plaque peeling. So once I make the cut, put the sodium hyaluronate, make a little bit space between the anterior capsule and the anterior capsular plaque, and do the reverse plaque peeling. So by doing the reverse plaque peeling, it is easier than the posterior capsular plaque peeling. Second, yeah, fine. I would like to.
Yeah, I think that is very, the good way to deal with that. Why? Yeah. So what
it has not been described, but I have felt like it works.
Yeah, you have something to say, Dr. Kalpit. The second comment
regarding that sodium hyaluronate. Like always, we have to use the sodium hyaluronate. The point, like when we inject the sodium hyaluronate, keep the bore of the cannula towards the endothelium. But because like when we inject multiple and we inject towards the anterior capsule, it becomes the diluted staining. The stain goes away.
Yes.
So better to inject keeping the bore towards the endothelium.
Agreed. You always actually inject a little higher up, because otherwise you will lose the stain. You're absolutely right.
Yeah. As far as
regarding the
please, yeah. So as far as the larger plaques is concerned, suppose you come across like a 8 millimeter plaque. So how I personally deal it, I'll make like if I am planning to make the anterior capsule 6 millimeter. So at that level, at that diameter, I enter with the MVR. I'll make kind of a little larger opening, and then I use the vitrector. So I complete a 6 millimeter, leaving that 2 millimeter margin as the stronger support to the lens. So, but you have to be very careful when you are doing the anterior limbal approach vitrectomy, posterior capsule vitrectomy. So you have to negotiate in a very proper way so that it should not extend.
Usually the cut rates, you can keep it, instead of keeping it very high, if you're a beginner surgeon, keep the cut rates a little low and the vacuum a little high if you have very thick capsules, and press your foot switch fully. So the cut rate should be, if you're a experienced surgeon, you can keep your cut rates high. If you want a very controlled capsulotomy with a cutter, keep the cut rate low, around 500, keep the vacuum a little high, press your foot switch fully, you will get nice, very controlled cuts, and you can get a nice opening in the fibrous anterior capsule as well as your posterior capsule.
True, that is
Agreed.
true. But it happens that every, like all anterior segment surgeon doesn't have that good vitrectomy cutter, and so.
True, this is Dr. Kalpit. I know him from a long time. He's a wonderful pediatric cataract surgeon from Ahmedabad. And the technique you are describing is something that's very nice. We have been talking about posterior capsule plaque peeling, but if you can, it's the same thing. If you can apply it to the anterior capsule, it would be really wonderful. And then you may not need your vitrector, maybe.
Regarding the hydrodissection, like earlier we were doing the multi-quadrant hydrodissection because it gets the easier and easily we can aspirate. But nowadays we have stopped doing hydrodissection because what we get, if we do the bimanual irrigation aspiration, the whole material will come as a jelly material. So there will be no any remnants lens fiber remaining stuck on the posterior capsule. So in case of pediatric, like I have started stopping doing that hydrodissection. I directly start with the irrigation aspiration.
Sure.
Any comment
That technique is nowadays no more practice. But for the novice surgeon, yes, if they feel difficulties, so yeah.
If you do a hydrodissection, to pull it off may be a little difficult. We also don't do any hydrodissection.
Yeah, I think most of us don't, but there's one catch. If you're doing especially multiple quadrant hydrodissection, you want to make sure that you don't drain out all your viscoelastic in doing, and if you do, please refill. Don't try to economize. And the other thing that can happen is sometimes your pupil can go small, or these many of these dysmorphic irises, I don't know how to describe them, but you can see those homogeneous patterns in many of these. So they tend to have a fluttery tendency, and if you do too much hydrodissection, it might come down during your surgery as well.
So in pediatric, and it can be that posterior capsule weakening, posterior capsular better not to do hydro if you are comfortable by doing that simple aspiration.
Thank you very much. Dr. Alok, please.
Yeah, though I am a cornea person, but after seeing your IC, I have not started developing interest in pediatric cataract. So my question is very simple. Which type of IOL do you use below 2 years of age? Like you have said, like Dr. Vivek has said, that you use about 10 millimeter overall size diameter. So which IOL is available in the market? Can you tell us?
Yeah, actually we don't have the customized IOLs of exactly the 10 millimeter, but I do use the what we use it for adult one, but for children they are like SA6080 and the MA6080. So that's overall diameter is 12 to 12.5. So if I want to choose to put those IOLs, those are not the IQ IOLs which looks kind of a yellow tint. Those are the normal white single piece.
We prefer
piece of
the
IOLs.
acrylic hydrophobic.
Yes,
So
yes.
which one is available? It's a customized or it's available?
No,
in
it's
the
a
market?
Alcan. It's available. They are
It's
available.
a regular adult size.
Yeah.
There's no
Adult
customized
size
lens.
without the yellow tinge.
Can I make a comment?
Actually,
Small. Yeah, please.
no, go ahead, please.
How
So-
it is following that diameter principle?
So
like
your point is very valid that ideally, I mean, globally there is so much need for this, but unfortunately because the whole market is driven by finances and economics and there's not so much demand supply for pediatric cataract, no company today manufactures of hydrophobic acrylic, at least not the multinationals, they don't manufacture smaller IOLs. So you have to put those bigger ones, and therefore sometimes squeezing them in a small eye becomes difficult. There are.
Sir, which age you prefer? Like below which age we
I
should
would
not
prefer, I prefer Alcon for all age groups of pediatrics.
even
Yeah,
at 6
actually-
months?
Even at 6 months.
Yeah,
Three-piece or single
Even
piece.
at 3 months, even at 2 months, because here age is not the guide. The guide is how much is your horizontal corneal
Word of
diameter.
caution, horizontal diameter you should measure.
Yeah.
If your horizontal diameter is less than 9, do not put the adult lenses. Do not. Leave them a faking.
Even I use little,
Little
the
higher,
yeah,
9.5 actually.
10,
9 I think to the range
10.5.
10. 10 is the safest.
Regarding-
If the corneal diameter less than 10, leave them a faking.
Regarding the size of IOL, IOC company is making a customized IOL that is of 10 millimeter, but the only issue with that it makes the hydrophilic, not the hydrophobic.
Exactly.
Otherwise, IOC is making that small size IOL. And regarding that, like 3-piece IOL, like in small eye, we used to put the 3-piece IOL. For 3-piece, like I am comfortable with that injector, with the B cartridge. Previously, when it was a rotating type, then it was a little difficult. With the injector type, with the B cartridge, even with that, you can manipulate the haptic once it goes inside. So, like I am not comfortable with the forceps, but 3-piece with the injector, I can also do, because in optic capture technique, we have to use the 3-piece IOL. So in that case, I use routinely injector technique.
Yeah, there, Dr. Kalpit, I think, we have to first press at the center so that make the optic concave
Yes.
within the, the tunnel of the cartridge. Then and then it goes smoothly. Otherwise, if it becomes convex, then
Yeah, we have-
Insertion
and
is
we have
important.
to
How you
see-
fold it is important.
And we have to see when you push the injector, it should push the IOL. It should not go in front of that IOL.
Yes.
So that you have to always observe.
Yes.
I think it's a matter of your own experience and your preference. Whoever is used to whatever. But both are equally good.
But the size of incision in that case,
It's
always
larger
we
in
have
the
to make
manual
3.2.
forceps.
That is true.
Definitely.
Right. I think for the benefit of the audience, since we actually dealt with all the technicalities of the surgery and all, I think follow-up is also one thing I just want, the house to, discuss, which means that, there is a lot of controversy exactly, like people have queries that when should we refract the child first, post-op, and, how often should we do it. So I'll just request the panel also to, probably just put in a word. I'll just tell my preference that maybe, when I'm operating, depending on the age of the child, 3 to 4 weeks after the surgery, I prefer to do an examination or anesthesia where we remove the sutures and, refract the child and give the best possible correction. If we left the child aphakic for any reason, then probably a contact lens fitting can be, done at the same sitting and they can be dispensed. And otherwise, appropriate glass, the spectacle can be actually, just given. And depending on the age of the child, again, if it's a younger child, probably we need 3 to 4 monthly refractions. And for a little higher age group, toddler and beyond, we generally, do it like every 6 monthly. And again, one more important aspect is that the IOP measurements, be very, very careful of, documenting those and not assume that everything is fine, because this is one of the aspects, the secondary glaucoma, post-cataract surgery, which is, probably underestimated, probably because we don't really have very good techniques of measurement. So I think that is also one aspect we need to understand. Every time we do a EUA, measure the corneal diameters if possible, and the IOP measurement. And in your routine OPD, probably the tonometers which are available, the eye care tonometer and all, can actually help you have some, access to what's happening, to the IOP. Can I just ask Dr. Guha, ma'am, can I just have a quick comment? Okay.
I agree with you that, even before surgery, I tell the parents, if you can't come for follow-up, don't do the surgery. You can't say that you live in villages and you will not come, because the incidence of glaucoma in following pediatric cataract could be as high as 35%. And believe me, it is a reality. And like Dr. Sumit said, every follow-up you have to measure pressure. You cannot not measure the pressures. If you can't do under anesthesia, we actually feed pedicloral to the child moment they come in, and we finished checking the fixation. We will feed them pedicloral so that by the time they reach us, they will be sleeping, and we go and take it with a tonopen usually. And sometimes if the child is well asleep, we can use a Perkins. But pressure needs to be taken. That is the bottom line, and you will have to explain this to the parents before the surgery. And the follow-up has to be done at intervals of 4 months when the child is very small, because you need to change the refractive errors. But then you can increase the follow-up as the child grows older. At least once in a year, pressure needs to be taken.
Yeah, so thank you, Dr. Sujata. So before I close this, instruction course, I would like to thank all the the audience for their kind patience, and all the speakers on the dais. Thank you very much.